Hello, thanks to everyone for watching this. It's my pleasure to talk about the treatment of ANCA-associated vasculitis. I'm Michael Walsh from McMaster University in Canada. These are my disclosures. Today I'm going to talk about two phases of treatment for ANCA-associated vasculitis, an initial or induction phase for therapy, as well as a remission phase. And you'll see here that this is really the entire message all on one slide, but we'll go through each of these components one at a time fairly quickly. So to start with, we'll talk about induction immunosuppression, which could be rituximab, IV cyclophosphamide, or oral cyclophosphamide most usually, although there are other alternatives that we'll quickly discuss as well. In terms of using rituximab or cyclophosphamide, there are two major randomized controlled trials that have been done that are most commonly cited as the evidence for rituximab being similar in effect to cyclophosphamide. The first is RAVE, that randomized 198 patients with moderately severe ANCA-associated vasculitis, and the other is RituxVas, which randomized 44 patients with fairly severe vasculitis. And you'll see from these slides that the outcomes, at least the early outcomes in both, were very similar, in that remission was induced in roughly the same proportions in each of those trials, whether they were randomized to rituximab or cyclophosphamide. So the choice of using rituximab or cyclophosphamide largely comes down to what are the other pros and cons of each of those drugs. For rituximab, we often say that it may be slightly more effective for patients who have had previously diagnosed disease and are now relapsing, and that's on the basis of a subgroup of patients in the RAVE trial. Rituximab is generally a bit better tolerated than cyclophosphamide, although IV cyclophosphamide is generally also quite well tolerated. There are, importantly, no fertility side effects from rituximab, and it does not increase the risk of cancer that we're aware of. However, it's not safe for patients who have known hepatitis B, and there is some uncertainty about the rapidity of onset of rituximab in that it may be delayed in its actions, even with fairly rapid B-cell depletion peripherally. And the last point I would make for rituximab is that if you intend to use plasma exchange substantially reduces the drug exposure to rituximab, which may decrease its efficacy, but at the very least deserves some consideration about when the plasma exchange and rituximab are used in terms of timing with one another. Cyclophosphamide, on the other hand, has some very nice features in that it has a very broad dose range, and so that if at first it does not seem effective, one can increase the dose often. It has an extremely long duration of effect. We can see the effects of cyclophosphamide lasting several years in terms of the risk of relapse after the initial 6 months dosing has been done. And there are some people who feel like cyclophosphamide is more efficacious for those who have renal disease, although this isn't well validated within clinical trials, and it is quite difficult to study. Some of the problems with cyclophosphamide is that it generally involves many infusions. So a full course of cyclophosphamide is 10 infusions over 6 months. A half course, which some people use, is 6 infusions over 3 months. It does require a fair bit of monitoring. In our center, we typically check complete blood counts and kidney function the week after each dose, as well as immediately before each dose of intravenous. It is a known carcinogen, and the risk of bladder cancer can be substantially increased, particularly after multiple courses of cyclophosphamide. And of course, it does have effects on fertility, causing infertility in those who are young and still of childbearing potential. And there are some problems with it exacerbating nausea and gastritis, which does sometimes seem to compound the effects of prednisone or the side effects of prednisone. There are, of course, other immunosuppressants to consider. So mycophenolate mofetil, or MMF, or Myfortic MPA have been used also. They have been compared to short courses of IV cyclophosphamide, where they look similar in their effect, but there appears to be a higher risk of relapse. And it's uncertain whether or not the MMF is particularly effective, or whether or not it is predominantly the use of steroids during that time that makes it look similar to IV cyclophosphamide. Methotrexate has been used many, many times for many years, but it carries a very high risk of relapse upon discontinuation of the drug. And of course, it's contraindicated in severe renal disease. Intravenous immunoglobulin, or IVIG, has been used several times, but there's very little information to really compare it to other immunosuppressants. However, it does appear to be sometimes useful in patients who cannot receive further immunosuppression, such as those who are already septic but suffering from active vasculitis at the same time. And finally, leflunomide has been tried in small trials, but there's very little information to be able to compare it to modern immunosuppression. And much of the use of any of these medications, including rituximab and cyclophosphamide, often come down to the logistic components of whether or not they're accessible, whether or not infusion centers are available, and whether or not the patients are able to afford them. If we move on to glucocorticoids, or now also glucocorticoids in avacopan, we have lots of new information to think about. There's really been three major trials in the last few years that have informed our use of glucocorticoid tapering regimens in ANCA-associated vasculitis. The first to come out on the far right was Pexivas, which tested a standard versus a reduced dose regimen of glucocorticoids in patients with severe ANCA-associated vasculitis. You can see in the bottom row the cumulative dose at 6 months for each one of these regimens. And in Pexivas, it was roughly a 40% reduction between the standard and reduced dose arms. The next to come out in the middle was Lovas, which looked at patients with non-severe disease, all in Japan, and almost exclusively who had microscopic polyangiitis and were MPO positive ANCA. There you can see that they have fairly high dose exposure in the high dose group and very low dose exposure in the low dose group, almost a 70% reduction in oral glucocorticoids between high dose and low dose. And finally, you can see the Advocate trial, which rather than testing two prednisone regimens, tested what was considered a standard of care prednisone regimen against avacopan, not quite as replacement, as the vast majority of patients received at least some glucocorticoids, particularly in the first 4 to 6 weeks of therapy. You can see at the bottom, although they were aiming for no glucocorticoids in the avacopan group, in brackets below is the cumulative exposure was actually about 1.3 grams compared to 3.6 grams in their prednisone group. And that's actually fairly close to the low dose Lovas group as well, and the standard or high dose Lovas and Pexivas groups for their prednisone arm. Just bear in mind that that's 1.3 grams in the Advocate avacopan group in addition to receiving avacopan. And what did each one of these trials show? Well, in Lovas, those patients who had a low risk of kidney failure were at low risk of death and had a low risk of relapse, predominantly MPO patients with normal creatinines. The reduced dose of glucocorticoid and their high dose glucocorticoids showed roughly the same remission, roughly the same mortality and kidney failure rates, but a dramatic reduction in serious infections at almost a 60% or 70% relative risk reduction. The Advocate trial for those who had moderate risk of kidney failure and death and relapse, who were a mixture of MPO and PR3 positive ANCA, and had typically fairly mild kidney disease, although there was a small subset that had more advanced disease. They again showed slightly or very similar remission, or maybe slightly improved, although that was after some differences in glucocorticoids over 52 weeks. They showed basically the same mortality and kidney failure rates, although there were very few events. And they showed really no change in infections despite the 65% reduction in oral glucocorticoid exposure, possibly because of the effects of avacopan, with an absolute risk reduction of 2% that crosses the null minus at 9.5% reduction to a 5.6% increase in risk of serious infections. Pexivas, the largest of these trials, showed a 40% reduction in oral glucocorticoids in patients who are at high risk of kidney failure and death and at moderate risk of relapse, a mixture of MPO and PR3 disease, but moderate to severe kidney disease and lung hemorrhage. Again, remission was essentially the same regardless of the glucocorticoid tapering regimen. Mortality and kidney failure were the same, and there was a roughly 30% reduction in the rate of serious infections for those who received reduced dose glucocorticoids. So if we put this together, then the Pexivas reduced dose glucocorticoid regimen is appropriate for most patients with renal involvement. You should consider adjusting it if the response is not as expected, but not before. Don't try and change the dose regimen on the basis of what you think might happen. Avacopan with prednisone is appropriate for most patients as well. You always start with the induction therapy, not months later, so that you actually achieve steroid sparing. in order to gain extra benefits with avacopan. But there are some uncertainties still around avacopan, and that includes whether or not it's really appropriate for those with very severe disease. There's more data coming out, but none of it randomized right now. There is also some uncertainty in who is most appropriate for a steroid-free regimen. So you can give avacopan without prednisone, but it's not really clear who that is most beneficial for. And we do suggest that you watch those patients very carefully for delayed responses to treatment or early relapses. And there's also uncertainty in its role after 52 weeks. It was only tested up to 52 weeks, and it's not clear if it should be used longer than that. And the low-VAS regimen may be appropriate for those with uncomplicated, low-risk ANCA-associated vasculitis. But remember to, again, adjust the dosing if things are not going as expected, and to watch very carefully, as in our practice, there aren't very many patients that actually fit the low-VAS kind of profile of being very low risk and being MPO positive. So we'll move on to plasma exchange, the last component that we're thinking of currently in terms of induction of remission. There's been many trials done over the last 40 years of plasma exchange in ANCA-associated vasculitis. These have been summarized most recently in a meta-analysis in 2022 in the BMJ, where there was no effect found on mortality. There was a decreased risk of kidney failure, which you can see in the left-hand forest plot, where at the bottom it shows that there's roughly a 40% relative risk reduction in end-stage kidney disease at 1 year. But there was also an increased risk of serious infections, which is shown in the right-hand forest plot, where at 12 months there was roughly a 28% increase in the risk of serious infections for those who received plasma exchange. So it does reduce the risk of end-stage kidney disease for the first 12 months, but it also increases the risk of serious infections over the first 12 months. Now, patients with ANCA-associated vasculitis have very wildly different risks for both end-stage kidney disease and for serious infections. And so it's important to consider what your patient's risk of end-stage kidney disease and serious infections might be when considering this therapy. We can see in this table that for those who are at low risk of developing end-stage kidney disease, down in the 0.2 or 5%, you would have to treat between 50 and 1,000 patients with ANCA-associated vasculitis to prevent one case of end-stage kidney disease. Those are people with generally creatinines of less than 300 when they're presenting. But if you go up to those with creatinines of greater than 300 who have between an 11 and 40% chance of developing end-stage kidney disease, well, then you need to treat anywhere between 7 and 25 to reduce one case of end-stage kidney disease within the first year. Unfortunately, those patients who are at high risk of developing end-stage kidney disease are also at higher risk of developing serious infections. And so it's likely for each one of those patients that we prevent end-stage kidney disease in, we're going to cause at least one more serious infection for those high-risk patients. You can see down in those bottom two rows. So we have to be careful. We have to use it in patients that are the most likely to benefit, but then we need to watch for the risks of infection very carefully, since serious infection is the most common cause of death in ANCA-associated vasculitis. Plasma exchange in patients with ANCA-associated vasculitis and diffuse alveolar hemorrhage, or DAH, requires its own special mention. It's been used very commonly in the past. It's been highly advocated by some people. But in fact, there is no mortality benefit that has been seen in any of the randomized trials. Mortality remains very high in these patients, but it's not necessarily improved by the addition of plasma exchange. We also didn't find that it improved the duration of ventilation. There was no reduction in duration of ventilation with plasma exchange, and it does still increase the risk of serious infections. And infections are one of the largest risks of death for patients who have severe alveolar hemorrhage. So we suggest that it's only used if there is a concomitant serious risk of kidney failure, or the risk of death is so high that plasma exchange can't possibly add to that risk. But when we talk to our critical care colleagues for patients who are ventilated because of their diffuse alveolar hemorrhage, they often say that they can't really differentiate who is at such high risk that it's worthwhile using plasma exchange for. So that would be an uncommon indication in our practice. These are summarized both in the recommendations that were published alongside the meta-analysis in the British Medical Journal in 2022 and in the 2024 KDIGO update that you see on the left-hand side, where they said consider plasmapheresis for those now with a creatinine of over 300 micromoles per liter, or 3.4 milligrams per deciliter. Okay, if we move on to remission maintenance, again, this is all summarized in this slide in just a couple of lines, that the two major treatments that we have available to us are rituximab, or a combination of azathioprine and low-dose prednisone. And in those who can't tolerate those medications, you could consider mycophenolate or methotrexate. So just comparing rituximab to azathioprine prednisone combination therapy, there's been two large major trials that have showed that, in fact, rituximab is far superior to azathioprine and prednisone. In both of them, there is risk reduction on the order of 50 to 70% for those that receive periodic rituximab. And that's two different regimens. One is giving it approximately 500 milligrams every 6 months. There is technically in that protocol the use of an additional 500 milligram infusion at the beginning of remission maintenance. That is used variably in clinical practice, however. And you can see that on the left-hand side in the main Ritsane trial. On the right-hand panel, you can see a gram given every 4 months in the ritazarin study. And again, both of those show that the therapy lasts for about a year after the rituximab is given. And they're both highly efficacious. But, and this will lead into our next slide, you can see in that right-hand panel that the effect starts to wane. The relapse rates start to pick up again in rituximab treated patients about a year after the last dose of rituximab is given. And so that brings us to thinking about the duration of therapy. Really, for patients with ANCA-associated vasculitis, they seem to remain at risk of relapses for well beyond 4 years. And so you can see that in the REMAIN trial, where all patients were treated with azathioprine and prednisone, but half had it withdrawn early and half had it continued out for several years, that those who continued out on the blue line did better at surviving without relapse, and those who had it withdrawn early relapsed at a fairly frequent rate for the entire duration. On the right-hand panel, you can see a very similar result with using rituximab. In patients in main Ritsane 3, they were randomized after having already received about 18 months of rituximab to carrying on for another 10 months or to having a placebo infusion instead. And those who continued to receive rituximab had a very low relapse rate compared to those who went on to placebo. And so it does seem that giving longer courses of maintenance immunosuppression reduces the risk of relapse for the period that it's given. So my take-home message is overall, rituximab or cyclophosphamide, both very reasonable choices for induction therapy, and you have to decide which one would be best for your patient on the basis of availability, the side effects, and the contraindications for each. The Pexivast reduced dose prednisone taper is appropriate for most patients, as is avacopan with prednisone for at least 4 weeks. They have very similar induction of remission rates, and they both seem to reduce the risk of infections over the higher dose protocols that we used in the past. Plasma exchange is useful during induction, but only for those patients who are at higher risk of dialysis dependency, renal failure. It should be used only for those or for that purpose to reduce the risk of renal failure. And maintenance with rituximab is almost certainly more effective than azathioprine and prednisone. There is a large gradient of the risk of relapse, and so you may still feel very comfortable using azathioprine and prednisone for those who are at slightly lower risk of relapse, since it still looks like it's an effective agent. But for places where you can, rituximab is generally preferred, and longer durations of maintenance therapy, up to 4 years, seem to reduce relapses, but they do increase the risk of side effects as well. And for those patients who might be at very low risk of relapse after a few years, withdrawal would seem like it would be reasonable, although there are more studies coming out to try and inform that. And with that, I'd like to thank you for your attention and wish you good luck in the remainder of the course.